Good afternoon, everyone. Here's a notable fact. Each American pays at least $1,000 annually in additional healthcare costs due to health inequities. And these costs come in the form of additional premiums, co-pays, and even taxes. And today we are going to present a solution that creates an ecosystem of health equity stakeholders and data systems to provide data insights and interventions that will improve member engagement, because we believe member engagement is the crux of improving health disparities or decreasing health disparities. Health disparities exist in life expectancy, maternal mortality, and health status across race, ethnic, and gender groups. And if these disparities are not addressed, it will cost the healthcare system about $1 trillion by 2040. And as you can see, diabetes, the disparities in diabetes itself between African Americans and whites cost about $15.6 billion in additional healthcare spending. Now, the factors that lead to healthcare disparities can be addressed through smart, focused, and timely interventions. However, the current ways of segmenting and prioritizing the members only takes into account the clinical factors, the clinical conditions, and therefore leaves out the social determinants of health and the social and other issues that the patient might be or the member might be facing. Another fact to note is 10 to 15% of Medicaid members are flagged as non-users. What that means is they have not accessed the healthcare system in the last 6 months due to various reasons, including access to care. And our aim for application is to address that main issue of access to care. Here's the CDC framework, in which measurement is the key to a successful health equity initiative, along with the other 3 pillars listed here. And our solution will focus on the measurement aspect of it. In a future version, we hope to address policy programs and infrastructure as well. As I mentioned, we will focus on the measurement aspect. So HEQ360 will orchestrate the different data sources to quantify the health disparities, prioritize the members for outreach and interventions, and identify the interventions most likely to succeed in that target population, and also provide actionable insights for the payers to take action. Here's an MVP of our HEQ360 tool. As you can see, this is just one section of it. Here's the analytics piece of it. We'll provide insights. And then here are some success stories from the field. So if homelessness is a primary concern for these members, or these members are homeless, I think that should be addressed first. And so we will highlight the reasons why homelessness should be addressed first, because there'll be a little bit of analytics behind it, and we will show them statistics to support why that should be the primary factor that should be addressed, and not worry about other factors at that point of time. Our business model is we'll offer this as a SaaS product, and the subscribers will pay a per member per month fee, or given the amount of spend that is in healthcare, we could also go for a value-based payment structure. The increased member engagement, we believe, will result in significant cost savings from reduced resource use, but most importantly, from decrease in inappropriate utilization of services like ER and inpatient visits, and better coordination of care for the members. Of the total market, we are going after a small sliver of the small and medium-sized Medicaid plans, and try to help them address impact $130 million in additional spend that they incur due to health disparities. There's a number of analytical tools in the market, but we differentiate ourselves based on our customized insights and interventions and information on successful interventions, as well as our core focus will be health equity versus general care management programs. We will complete our product validation with at least 2 Medicaid payers by the end of 2023. And in 2024, we will wrap up our marketing and sales effort to acquire additional customers with a target ARR of 5 million by end of 2027. Now, there are 2 things that would work in our favor. The regulatory requirements around health equity programs and reporting are changing, and it will force the health plans and payers and health organizations to have health equity programs in place, and they will also have to license tools to manage those programs. And the other advantage we have is we already have a growing base of customers for our other products in the same market, so we'll be able to leverage them to increase our customer share. We have an experienced team, experienced, skilled, and knowledgeable team that will help and build and deliver a very effective product. Each of them have over 10 years of experience in their respective domains. Health disparity is a public health emergency, and it should be treated as such. And the time to act is now. As I showed you, there is $320 billion currently being spent, which will go up to $1 trillion. And we are inviting partners, payer partners, to work with us in validating the tool by sharing with us de-identified data and validating the tool for their population. Thank you.
Thank you so much, Aman. And thank you so much for the work that you're doing. Really, really important work that we need focused on health equity and these types of tech-enabled solutions. So next up we have for our judges is Terika McCall.
Hi, Aman. Thank you so much for that presentation. And it's good to see some work being done that includes looking at social determinants of health. So I just have a couple questions. So one of the examples you use, and I understand you're saying that you're looking to work with, for instance, and you can clarify are you working with community health centers, or because I know of like a couple community health centers that have already have data on like, social determinant of health data that they're integrating with the EHR data to then pass that on to caseworkers and connect people to, services they might need. For instance, those that are experiencing homelessness. Are you trying to target like those type of clinics? I'm not really sure who your target customer is.
So our primary customer at this point of time is small payers. So Medicaid, payers in the Medicaid space. But the idea here is the data insights will not only be shared or used internally, but they will also be shared with their partners. Now, if you see the screen here, right, we already have the components for building an ecosystem that can allow the community health centers, the not-for-profits, the providers, and the payers to work together, share data, share insights, and work together on the same programs. So ultimately, and as I mentioned in one of the slides, right, in that 5-year period, later on, we will be working with health systems and not-for-profits and other organizations, because the tool is meant to be an ecosystem. But to begin with, we will just focus on the analytics, because based on our discussions with at least a couple of payers, and one payer has already agreed to do the pilot with us, it's a Medicaid plan in New York. They have a lot of data, they have a lot of tools, but they don't really know where to focus on. And they keep spending money on these resource-intensive care management activities.
So then basically with this data, then clinicians or who will have access to, for instance, like a data visualization platform to actually do some actionable items? I understand that you're saying that you're creating this ecosystem, but once you're incorporating the social determinants of health data and saying, okay, this person is experiencing homelessness, then what? I'm trying to get to like. Sure,
great question. Right. So this screen that you're seeing right now, this will underline under this screen would be a BI tool. We would obviously generally create a lot of these pre-packaged reports and analytics and insights, and then those insights. So say, for example, homelessness is identified, right? So these members, so we would create an API to a vendor that addresses this issue of homelessness. Maybe it could be a CBO. And so that data would automatically go through that vendor through an API, and obviously whatever work they do, that will come back into the system. Similarly, a food desert or somebody who has issues with transportation, right? Whatever the case might be, that we would then link that data or create that API to share that data immediately with that vendor. And then obviously there would be a feedback loop as well. So that's the idea. So behind each of these elements, we would work with the payer to figure out who are their partners. Is it themselves internally, or do they have external partners who can address these issues? And having worked with NHI population, we have seen the advantage of using CBOs for a lot of the outreach, and it's very effective. And again, this is in New York. I have worked my entire life in New York, and half of it has been with Medicaid plans. So
Thank
I've
you.
seen this firsthand, yes.
Thanks.